Uh, Achalasia cardia, as you know, is a rare disorder, mortality disorder, and there are many patients coming to us with a history of uh, vomitings and regurgitation, and there is most of the time dysphagia. So these patients may be younger patients, and they require some form of counseling initially, and then you have to make a diagnosis. And once the diagnosis is established, you proceed with the management of Achalasia cardia. There are many options available. One is the surgical option, Heller's myotomy, which has been the initial one, which has been there for a long time. With the advent of laparoscopic surgery, now laparoscopic Heller's myotomy is being done. So surgical option is there. But this surgical option has many positives and many negatives. So the lesser option would have been balloon dilatation, which is being done for many other disorders also. So this is being practiced in many centers of the world. In the Department of Surgery at our medical college, this endoscopic unit is our responsibility, and we have been doing it for quite some time now. And we have been doing therapeutic endoscopy procedures also. And this is one of the cases which we want to show you, that we have done esophageal balloon dilatation and in a young female who came with the diagnosis of Achalasia cardia. So please open the slide. Endoscopic balloon dilatation, this is the topic. Next, let it come. Now, the patient profile, a 25-year-old female, reported to surgery OPD of the Jain Medical College with the complaints of dysphagia and vomiting of food taken earlier for the last 1.5 years. She had tried various forms of treatment, but her dysphagia did not improve. Now we see this X-ray. Okay, it's going very fast. Now this is our patient who had this history of dysphagia, and we are going to perform esophageal balloon dilatation, and there is certain modification in this technique. Now, as you can see the guide wire, and you can see all the things there, the balloon and the pump, etc., ready for the procedure. And the patient has been made to lie down in the left lateral position, and the endoscope is introduced. Now, you can see the endoscope is going inside the oral cavity, and then it will be entering the upper esophagus, and you can see food particles and a lot of fluid inside. Some has already been sucked out. So you can see the endoscope going down gradually towards the lower end of the esophageal sphincter, which is the area which is the diseased area. And you can see the sphincter is very narrow, and there's hardly any opening inside this part. So this opening is very narrow, and probably this is the area where the food is getting stopped, and it cannot go beyond this. Now with the endoscope, we have negotiated the area, and we have entered the stomach, and the stomach also contains large amount of food particles. And now this is the pre-pyloric area, and we are entering the pyloric area finally, and that is the pylorus. You can see the pylorus there. So now once we have done an inspection of the stomach and the duodenum, we are coming back into the esophagus, because we have identified the area which needs the procedure to be done. So that is the area. Now once it is a modified video, so the whole thing cannot be seen. Now you can see the guide wire is being passed through this endoscope, and you can see the guide wire coming inside the esophagus, and this guide wire is gradually being introduced through that narrow opening which is there at the lower end of this esophagus. Now this is the guide wire tip, and it is going inside the esophagus, and now it has entered the stomach, and the guide wire is slowly being, the endoscope is slowly being withdrawn, and you can see the guide wire coming outside, and it will come outside the oral cavity. Now this is outside the oral cavity, and the endoscope has also been withdrawn. Now the guide wire is inside the oral cavity, and now what we are going to do is, you can see the balloon. Sorry. I'm sorry with the... Okay. Okay, put it on.
Audience is also requested to keep the telephone on the vibrations.
Yeah, now you can see the balloon being introduced inside the oral cavity. Some lubricant has been applied, and it is being introduced slowly through the oral cavity, and this is a blind procedure, and many surgeons, many endoscopists use the fluoroscopy to do this, but we have modified this procedure, which we will show you later on. Now once the balloon is inside the upper part of the esophagus, the endoscope is being introduced again. Now this endoscope, now you will have the whole of endoscopic vision, which is a slight modification from the previous procedures which were being done. And now you can see the whole of the esophagus. I'm sorry, being the organizing secretary, you get telephone calls at odd hours of the day and night. So I have to keep my phone on. I'm sorry for that interruption. Yes, put it on, please. Now, as you can see, the balloon, this balloon is at the lower end of the esophagus and is being introduced inside the gastroesophageal junction. And now you can see the bluish part is the tube and the whitish part is the balloon. Now the balloon is just at the GE junction, and this is the tube part which is connected to the balloon. Now we will go and inflate the tube, the balloon, to a pressure of 200 millimeters of mercury, and we'll keep that dilated for 1 second, 30 seconds initially, and then we'll increase it to another 30 seconds, and the maximum time which is there for the balloon to be there inside the GE junction is up to 2 minutes. So in this particular case, we did it for 30 seconds, and then we did it for another 1.5 minutes, and you can see the balloon being inflated to 200 millimeters of mercury. And this is being done, and we are timing the time to which the balloon will be inflated inside the esophagus. Now this inflation has been done, and now you can see the inflated balloon. Part of 2/3 of the balloon is inside the gastroesophageal junction. It has gone even beyond that, and part of it is in the stomach, and the rest, most of it is in the GE junction, and small part in the distal esophagus. So now we keep it for 2 minutes maximum, and then we deflate the balloon. Now once the balloon, this is a fully inflated balloon, as you can see, and we are waiting for the time to finish. So once the time is over, somebody has to time this particularly, otherwise if it goes beyond 2 minutes, it can damage the sphincter and can cause many complications such as perforation. So now it is being slowly deflated, and now you can see the balloon being withdrawn, and it is coming out from the gastroesophageal junction. Now you see the balloon has been withdrawn nearly completely, and that is the lower esophagus. And what we want to see here in this is that whether there is hematoma or any injury or any perforation, which is not seen very nicely through the endoscope, so you have to resort to radiological measures later on. But you can see the effect of the dilatation. You can see some bleeding spots. This has to be seen, otherwise that shows that how effective is your dilatation. Now once that dilatation has taken place, now the esophagus, you can see the dilated GE junction. Initially it was pinhole, now it is nearly completely dilated, and the scope can be pushed inside very easily, and the whole esophagus is dilated, the lower part of the esophagus is dilated, and you can see there is no apparent injury to the lower esophageal area. But you can see the opening, which is very clear. Initially you had seen it that it was very narrow. Now you can see a wide opening because of this dilatation procedure. So that completes the part of the dilatation, and we are just having an inspection of the rest of the GI tract, upper part, and then we will withdraw the endoscope. So by doing this, we have been able to dilate the lower sphincter. Audio on. Audio on. Full karo. Just go back to this slide. Audio on करो भाई. इसको कैंसिल कर दो. कैंसिल कर दो. नहीं उसको सुनाना है ना, वो जो लड़की बोल रही है. पूरा नहीं, लास्ट का पार्ट बस. नहीं बता देंगे उसकी मुंह. You hear from the horse's mouth. That is always better.
ग्रुप पे जाता था, उल्टी हो जाती थी खाने में. उसके बाद मैंने डॉक्टर साहब को दिखाया, उन्होंने मेरा दूरबीन द्वारा जांच की, उससे मुझे फ़ायदा है. अब मैं खाना खा लेती हूँ. जो उल्टी होती थी वो उल्टी नहीं होती, अब खाना चला जाता है आराम से.
So you have seen that this procedure can be completed in around 10 minutes, and the patient goes home the same day. The only precaution is that you have to verify that there is no esophageal perforation. So for that, we usually do a X-ray chest and X-ray abdomen, and sometimes if needed a gastrographin study. So this procedure is being done in our hospital, and I think gradually we will gain more experience on this, and we will be able to treat most of the Achalasia cardias in this particular way. The difference from other studies is that this procedure is being done, but they are using fluoroscopic control. So when they put the guide wire, then once they are introducing the balloon, they sit under the fluoroscopy. Now the fluoroscopy has to be there for a long time, because they have to position the fluoroscope, the balloon in such a way that it is at the G junction. So for that it takes a lot of time, and extra exposure to radiation is there on the patient. Now with this technique by which we are introducing the endoscope directly under vision, and you can see the lower esophagus, and you can see the balloon dilated, and you can see if any other complications occurred. So I think this endoscopic balloon dilatation without fluoroscopy is a better procedure rather than using the fluoroscopy. So there's a debatable topic, and of course the time is short, so I'll conclude here. Thank you very much.
Sir, thank you very much, sir.
She has been followed up for up to 3 months now, and she is very comfortable. Of course, as you have rightly pointed out, generally there is failure rate at the end of 6 months and 2 years. So they say that 70% of the patient will become all right, and 30% will need a second dilatation after 2 years. So if this patient comes again, we will do a repeat dilatation, and after 3 dilatations, if patient does not respond well, then the surgery is the answer. So surgeons are always ready to do it. So we have those options available. So this is a primary procedure, and after that, if it fails, you can go over to either laparoscopic hairless myotomy or the standard hairless myotomy.
Thank you, sir.
Thank you very much.
Thank you so much.